Welcome back to the Conundrums in Human Reproduction. I'm Leslie Blankenship-Williams. I have a doctorate in biology. I also teach human physiology and microbiology to allied health pre-professionals such as nursing students and physician's assistants, and I also work as an embryologist in an IVF laboratory. In this discussion, we're going to build upon our previous lecture, which looked at the IVF process in total. And we're just going to look at one aspect of IVF, and that is the genetic testing of the embryos. So genetic testing of embryos has quite a few controversies, conundrums, or ethical dilemmas embedded into that process. And so it's not a cut and dry procedure, and there's definitely some concerns. So we're going to take a look at what type of genetic testing has been done, what the future of genetic testing might look like, and then what the ethical dilemmas are. So once again, there's no right or wrong answer. I'm simply just trying to broaden your knowledge base and have you think a little bit more deeply about some of the issues facing IVF. Before we get started, we are going to look at a brief history of how IVF has been viewed from a social standpoint. In order to address this, we need to ask the question, why do people use IVF? The most common reason is infertility. And infertility is generally defined as the inability to conceive following 12 months of unprotected sex. It can also include individuals who repeatedly conceive but also repeatedly miscarry. So the first baby to be born via IVF is named Louise Brown, and she's actually my age. She was born in 1978, and she was born to a mother who had blocked fallopian tubes. So the mother was infertile because the fallopian tubes did not allow the passage of a fertilized egg down to the uterus to implant. And so she was sometimes heralded as a test tube baby, though technically she's really a petri dish embryo, and I wouldn't even say baby, but an embryo. With the birth of Louise Brown marked the beginning of IVF, and also the ethical concerns around IVF. So in the early days, IVF was actually considered kind of a taboo procedure, and there were serious concerns, warranted concerns, about the health and safety of children that might be conceived by this avenue. And the reason why I said these were valid concerns is because there's no data to draw from. When you first start a new experimental procedure, you don't have the long-term data to draw from. So questions that were definitely on people's mind about this new, experimental procedure is, would it be effective? Would it be safe? And most importantly, would it produce healthy children? Religious organizations, in particular, were often vehemently opposed to IVF, and some still are, because it was akin to playing God. And finally, an issue that still remains today is IVF potentially a form of eugenics, and should we be doing that? Regarding the effectiveness of IVF, I'm happy to say the field has and continues to advance, and many millions of babies have now been born successfully via IVF procedures. Moreover, our long-term data on the health and well-being of children born through IVF show that most of the safety fears were not realized. Some of the ethical dilemmas, such as the potential to use IVF as a way to achieve eugenics, remains, and we're going to discuss that here. But suffice it to say that while IVF was once taboo, it's gained mainstream acceptance and is responsible for 2% of babies born in the U.S. every year, and in fact has contributed an additional 10 million people on this planet. As stated previously, IVF was developed primarily to assist with infertility, and not just female infertility, but also male factor infertility. Today, the application of IVF is much more expansive. IVF is used whenever you have a couple that need to use a gestational carrier. So an example of this would be a woman whose uterus is unable to support a pregnancy or their uterus was removed. If you have a male-male couple you would require a gestational carrier, and so IVF would also be used there. In fact, IVF in general is used a lot for same-sex couples or a single parent wishing to conceive. Intended parents where one or both have cancer and they know their cancerous treatments are going to damage the reproductive tissues and cause infertility may elect to do an IVF cycle or part of an IVF cycle in advance of that cancer treatment. And also, IVF is indicated when one or both parents has a serious hereditary disease. And this offers a way to select against specific genetic diseases and try to make sure that the embryos do not carry the genetic disease. In our current culture, having children and caring for them is considered to be a noble and worthy endeavor. And so at this point, I argue that IVF is generally accepted in mainstream culture. Part of it is because we support families wanting to grow, and often this is now recognized as the only way that can happen. But I want to go a step farther and talk about the fact that IVF requires significant investments, both financial and health-wise. And I argue, and it is my personal opinion, that the intended parents are putting significant skin in the game, so to speak, and that is rewarded by a cultural acceptance of IVF. A single IVF cycle is incredibly expensive. $20,000 might be a typical cost, and a baby is not guaranteed at the end. Many insurance companies do not pay for IVF treatments, and many people do not have health insurance. So therefore, this is often paid for out of pocket. Moreover, the process of IVF requires a whole lot of injections that are no fun, and it's physically and emotionally taxing. So people who are willing to undergo IVF are being subject to financial, physical, and emotional hardships, and again, for the noble goal of expanding their family. And I believe this is one of the reasons why IVF has gained mainstream acceptance. Even most religious organizations support IVF processes, at least for heterosexual couples experiencing infertility. Notably, Catholicism is still an exception to this. While IVF as a whole is accepted, there are many aspects of IVF that remain problematic and clash, sometimes starkly, with religious views, personal morals, and ethical viewpoints. And in the United States, a lot of aspects of IVF don't have clear guidelines, further muddying the waters. And that's really what we're going to look at today. So our conundrum of the day is based on genetic testing of embryos. And we're going to start diving into what makes this particularly ethically sensitive and difficult. But again, before we get into that topic, we have to backtrack and go, why was this even developed in the first place? Why do we even do this? And when did it become potentially controversial? So let's get into the history of genetic testing in IVF. So here's the underlying tenet. Only embryos that are chromosomally correct are going to result in a healthy baby. That was such an important sentence. Let's say it again. Only embryos that are chromosomally correct are going to result in a healthy baby. In order for an embryo to be chromosomally correct, we need 23 chromosomes from the egg and 23 chromosomes from the sperm together to make 46. So this is the correct number of chromosomes. We have 2 of each type. 1 copy from the egg, 1 copy from the sperm. These chromosomally correct embryos are termed euploid. So only euploid embryos are going to result in healthy babies. The problem is that in order to have a euploid embryo, the egg had to have 23 chromosomes and the sperm had to have 23 chromosomes. And that doesn't always happen. In fact, very often it doesn't happen. Sometimes we get abnormal numbers, too many or too few. It's usually the egg, but it can be the sperm too. So what does that mean, abnormal? Let's consider this example where I have 23 chromosomes in one, like let's say the egg, but 24 from the sperm. That gives me a total of 47. So I have one extra chromosome in there. Or maybe I have one too few chromosomes, 23 in one gamete, and then the other gamete only has 22 for a total of 45. This is an abnormal number of chromosomes. So we call these chromosomally abnormal embryos aneuploid embryos. So again, we want the euploid embryos. Before going any further, let's take a look at this chart here. This picture shows us a schematic of a chromosome map for a particular, let's just say an embryo. Is this embryo euploid or aneuploid? If it's euploid, it's going to have 2 copies of every chromosome type. But you'll see that right around here, we're missing one. So this one is aneuploid. If this was the chromosome map for an embryo, this embryo would never develop into a baby. So therefore, we would never want to transfer this embryo into a uterus because we know it wouldn't go anywhere. So what we really want to do is be able to separate out the euploid embryos from the aneuploid embryos. And therein lies the beginning of genetic testing. So our rule of thumb is that we want only euploid embryos, and we want to not transfer the aneuploid embryos. So aneuploidy actually is strongly correlated with female age. And in fact, aneuploidy is considered to be the #1 cause of infertility. So if you have a woman who is 40 years of age, and she has an IVF cycle, and there are 10 embryos at the end that are potentially well developed enough to be transferred, how many of them are going to be aneuploid? Probably 8 or 9. So that means only 1 or 2 are likely to be euploid. What if a woman was my age? So I'm 44. First of all, the likelihood that I would have 10 good-looking embryos towards the end of my cycle is very low. But let's just say I got really lucky and I had 10 really good-looking embryos. What is my expected number of euploid embryos? 0. I expect 0. Now, that's not to say it never happens, but that's my expectation. I expect them all to be aneuploid. So you can see that, once you start getting over the age of 35, aneuploidy is increasingly an issue. And so the real rationale behind genetic testing of these embryos is to actually be able to differentiate between the euploid ones and the aneuploid ones so that you only transfer the euploid ones. Now, hopefully I have convinced you of the merits of testing for aneuploidy, but interestingly enough, this is kind of a recent adoption in the United States. In 2013, maybe 25% of IVF clinics were routinely offering testing for aneuploidy, and it isn't until now, 2022, that I would say, yeah, it's pretty much routine. There are still clinics out there that don't offer it routinely, and they have their reasons for that, but I would say it's more routinely offered now than not. So what did people do before this testing for aneuploidy was offered? Well, let's take a look at that, and that will help explain more about why it's offered so often. Let's say a patient who is 35 years old, experiencing infertility, comes into the clinic, does an IVF cycle, and at the end of her IVF cycle, she has 2 good-looking embryos, these 2 that are shown here. These are actually mice embryos, but we're just going to pretend they're human embryos, and she has these 2 good-looking embryos. And they both look pretty good, embryo 1 and embryo 2. They do not have any genetic testing. You have no idea if they're aneuploid or euploid. We say the chances of them being euploid or aneuploid are 50-50. So what do you do? Do you transfer one? Do you transfer both? What do you do? So this was the dilemma. If you just transfer one, there's a pretty strong risk that it's aneuploid. And it could be aneuploid in a way like it has trisomy 13, where it's not going to be a healthy baby at the end, but it might develop pretty far along. It could be aneuploid, so extremely aneuploid that it never develops at all, in which case there's no pregnancy. They could also both be euploid, and if you transfer them both, the idea is, again, one of them is probably aneuploid, so you kind of throw them both in there and say, let's hope that one's aneuploid and one's euploid and sticks. But what if they're both euploid? Then you have twins. And the problem with twins is that anytime there is twins or multiples, there are increased risks both to the developing babies and the mothers. So a lot of physicians in particular did not like transferring two embryos because of the risk of twins. And so they really wanted to come up with a way to try to figure out how to ensure that, one embryo, one baby type of a deal. And the way to do that is to discern between the aneuploid ones and the euploid ones. So this is what was done prior, is we did a lot of double transfers and we had a lot of twins and a lot of just kind of guessing. But now we have PGT-A, which stands for pre-implantation genetic testing for aneuploidy. And again, it's a pretty standard offer in most, though not all, IVF labs. This, by the way, is a very typical report for PGT-A, which again, pre-implantation genetic testing for aneuploidy. It's very commonly offered as part of an IVF package nowadays. In this example, we have 5 embryos that reach the blastocyst stage. The day refers to how many days post-fertilization the embryo reached its blastocyst stage. The grade refers to the morphological quality of the blastocyst. I'm not going to go into that here, but briefly, just like in school, a higher grade is a better quality embryo with a better chance of implantation. There is only a loose correlation between morphology grade and genetic result. In other words, you can't look at a really good quality one and say, oh, that's definitely euploid. And moreover, you can't look at a poor quality one and say, oh, that's definitely aneuploid. It's a loose correlation. In general, better looking embryos tend to be euploid than poor looking embryos or poor developing embryos, but it's very loose. So again, this underscores the importance of getting a genetic test rather than just looking at what does it look like. Here we can see that embryos 1 and 4 are euploid. Embryo 2 is missing a second X chromosome. Embryo 3 is trisomy 21. If transferred, there's only a 50% chance that that embryo will even result in a live birth, but if it does, that child will have Down syndrome. Embryo 5 is aneuploid in multiple ways, missing a second copy of chromosome 22, but also having an extra copy of chromosome 16. Embryo 5 is likely to not develop much further. As you can see, this genetic report is very informative and clearly identifies which embryos should be considered for transfer. As of today, many IVF clinics have adopted to biopsy all patient cycles, regardless of the age of the mother, and therefore PGT-A is widely adopted. When the Supreme Court overturned Roe v. Wade and the right to an abortion was left up to the states, many states either passed laws or reverted to old laws on the books that restricted these reproductive rights. And those restrictions apply to IVF patients too. For instance, some states no longer allow for a therapeutic abortion for an aneuploid fetus, for example, trisomy 13 or 21, or allow performing a D&C on a fetus that is dying but has not yet died, but when it does die, could induce life-threatening sepsis. So some of the other aneuploid embryos might implant and start developing, but then die, and if not removed in a timely fashion, could actually kill the mother with inducing sepsis. So in those states especially, the importance of transferring an embryo that is euploid really cannot be overstated. And so I personally support the widespread adoption of PGT-A, especially in light of Roe versus Wade being overturned. While screening for aneuploidy on its own rarely stirs up ethical debates, you might notice that the biological sex chromosomes are also displayed on the genetics reports. So generally, this means that the biological sex of the embryos are also revealed to the patients. Most, but not all, clinics that I'm familiar with will allow the patient some input into selecting the embryo that gets transferred, which brings up the question of whether or not IVF patients should be allowed to choose the biological sex of the embryo. What if this patient really wants a boy or an XY embryo? Here, we have two normal embryos, but they're XX. No normal XY embryos. So maybe this patient elects to spend another $20,000 on another cycle in hopes of getting a euploid XY embryo, even though there's two euploid XX embryos and one of them has an excellent grade and chance of implanting. So in this way, the revealing of biological sex can lead to ethical concerns in terms of selecting for embryos of a preferred biological sex, something that's not possible during natural conception. In fact, there are cases where couples elect IVF solely for that ability, meaning there's no infertility, there's no anything other than they want the ability to pick and choose which embryo is transferred. Should this be allowed? So consider that. And while you stew on that, let's take a look at some other uses of genetic testing. So embryo genetic testing can also be applied at a smaller scale, looking for genetic disorders that arise from a single gene or a specific region of a chromosome. There are over 200 different genetic disorders that are known that are carried on a single gene. And testing for one of these genetic disorders is termed PGT-M. So the prior genetic testing I talked about was A, PGT-A, and A stands for aneuploidy, which is looking at the entire chromosome. Here, we're just looking at a single gene. Typically, this is considered an add-on, and it's only done if one or both of the parents have tested positive for that particular gene. So many of these genetic disorders that are tested for as part of PGT-M are eventually fatal and have complete penetrance, which means that 100% of these individuals develop the severe and often fatal disease. Examples of these genetic diseases with 100% mortality eventually and 100% penetrance would be cystic fibrosis, Huntington's disease, Fragile X syndrome, hemophilia, beta thalassemia, and muscular dystrophy. So it's no surprise then that if one or both parents are carriers for such diseases, you would want to test the embryos to ensure that you're not transferring embryos that might develop those fatal diseases. The diseases that I just listed are not controversial because they're usually fatal and or result in significant developmental or progressive disorders. But what about genetic diseases that have less penetrance, meaning that not everyone who has that genetic profile actually develops the disease? Or what if the disease or disorder is not fatal? And I'll use myself as an example. So I actually have two genetic defects, one of which is that I'm hard of hearing. So I was born this way. My brother was born this way. Both of my parents hear perfectly fine. So we believe it is a genetic, maybe a recessive disorder, and it has definitely presented, in fact, daily challenges to living. Is it fatal? Not in a traditional sense. Is it more likely that I'm going to be hit by a car that I can't hear? Yeah, but it's not fatal in the same way that Huntington's disease is fatal. That said, it definitely reduces my quality of life. It is a handicap, it is a disability, and I don't necessarily want it for my children. So if I was going through an IVF cycle, would I want to identify the gene that causes my hearing impairment and select against embryos that carry that hearing impairment allele? And the answer is absolutely I would. Should I be allowed to? I mean, from a personal, selfish standpoint, I would say yes, because I can tell you how miserable it is to be hard of hearing all the time, especially when we're all wearing masks and I read lips. But it doesn't mean that I should be allowed to. And another example, I have celiac disease, which from a health perspective is much more serious. In order to have celiac disease, which is an autoimmune disease, you have to be genetically predisposed. So what that means is almost all the people that have celiac disease have a specific genetic profile, and it's on 1 or 2 genes. But not everybody who has that genetic profile develops celiac disease. What percentage of people who have that genetic predisposition actually develop celiac disease? I couldn't find the stats, but my understanding is it's like 5 to 10%. So I have the genetic profile for celiac disease, and I developed celiac disease. My brother also has the genetic profile for celiac disease, and he does not have celiac disease. We got these genetics from one of our parents, but neither of them have celiac disease. So in other words, just because you have the genetic profile for it doesn't mean you'll actually develop the disease. So should celiac disease be included in the pre-implantation genetic testing for monogenetic diseases when it has a low penetrance? And what that means is only a handful of people who have the genetic profile will actually develop the disease. I don't know. Again, from a selfish standpoint, if I were going through an IVF cycle, I would say, yes, I want to exclude embryos that potentially could have celiac disease later in life. But I don't know that I should be allowed to. So you can start to see how we move away from the cut and dry case of testing for a genetic disorder that is fatal and has 100% penetrance to looking at disorders that maybe aren't fatal or disorders that have a low penetrance, meaning not everybody who has a genetic profile actually gets the disease. And where do we draw the line? So going back to kind of our bigger picture for ethical concerns of PGT testing, I've created a spectrum. Now, this is my own interpretation of how generally people feel about these different uses of pre-implantation genetic testing. So in the spectrum, on the red side, I have non-controversial applications, meaning I think everybody who understands the use of this particular tool would say, yes, this is a good use, a non-controversial use of that particular genetic tool. On the purple side, we have uses that I think people do have potential ethical concerns with and do pose dilemmas. So again, this is my own interpretation of kind of how it falls on the spectrum, which may or may not match yours, because there's no right answer here. So looking at PGT-A, non-controversial, using PGT-A to basically identify non-viable aneuploid embryos and making sure they don't get transferred. I think that's cut and dry. That's the intended use of PGT-A, and so that makes it, nice because we don't want to be transferring embryos that are never going to develop. But there are some aneuploid embryos that might develop, but might still have defects associated with being chromosomally abnormal. And an example of this is trisomy 21, which causes Down syndrome, and also Klinefelter syndrome, which is XXY. And that was actually discussed in another lecture. And Klinefelter syndrome is going to be born as a male, so there's a penis and a testes, but develops more female-like secondary sex characteristics later on. And then with the aneuploidy report comes the biological sex determination, and the fact that intended parents are potentially allowed to select the embryos based on their preference for biological sex. So that is not related to the health of the embryo at all. That's entirely related to parental choice, and therefore I put it on the purple side of, there might be ethical concerns with that. PGT-M has more uses, and so there's more things to think about. So PGT-M is looking for that one gene, Again, on the cut and dry side of things, we have those single gene disorders that are fatal and have 100% penetrance. If you have 2 recessive alleles for cystic fibrosis, you are going to develop cystic fibrosis and it will be fatal. I mean, that's just what we know of. And so, yes, selecting against those embryos, I think, is pretty much non-controversial. Where it starts to get a little bit more iffy is when we look at diseases that, of course, might also be fatal, but don't have 100% penetrance. So, for instance, the BRCA genes definitely increase people's risk of breast cancer and ovarian cancer. But just because you have a BRCA gene doesn't mean that 100% of the time you're going to get breast cancer or ovarian cancer, or that it can't be caught or treated other ways. So what about those types of genes? Or what about genes that really just reduce quality of life but don't necessarily result in a fatal outcome? Or what about, and this is one I have not talked about actually, what about a gene that has nothing to do with the baby, but has everything to do with the mother and her pregnancy? So there is a gene that was identified, it's actually a set of genes called the M2 group. And when an embryo is positive for a specific allele, the placental uterus coordination is compromised a little bit, and it leads to pregnancy complications, developmental disorders in the baby, etc. We are looking to avoid transferring embryos that are M2 positive because they increase the risk of pregnancy complications for the mother. And then, although it is not, as far as I know, utilized yet, what really is the difference between being able to say, I want an embryo that is XY, or I want an embryo that is XX, from also saying, I want an embryo that has a specific skin tone and a specific hair color and lack of freckles and muscles that are enriched in fast twitch fibers. In other words, things that are going to be more aesthetic. And I'm not sure that there really is much of a difference, so I have that there on the purple side. Again, from a PGT-M standpoint, as far as I know, this is not offered, but it could be. And if it is, we definitely need to have that conversation about whether or not it should be. So you can see that the ethical concerns of PGT is not an easy conversation to have because it's not black and white. It falls on a spectrum or on a gradient. The examples in the previous slide concern disorders relating to whole chromosomes or a single gene. And these are relatively easy to test for, especially when the disease or alleles are known and well connected to a serious issue or disease. But many of the common diseases that humans face have links to multiple genes, a term known as polygenic. For this reason, a few genetic companies have started to offer what is known as PGT-P, and the P stands for polygenic. And this looks at whole genome genetic profiling, kind of similar to 23andMe if you've ever had your own genetic profile done with saliva. And it assesses the risk for a broader set of diseases with more prevalence, particularly in the United States. As of right now, in 2022, this is really kind of in the clinical trial stage. It's an emerging technology, still in its infancy, but I do expect to see more of this being offered by IVF clinics in the future. And one of the reasons is because these are much more common diseases that face adults. And if we could reduce the prevalence of these diseases, we create healthier individuals. But it's important to note that the penetrance of these genetic diseases is quite variable. And there are also environmental and lifestyle impacts as well. For example, just because a person has a genetic profile that increases the risk of type 1 diabetes does not actually mean that that person will develop type 1 diabetes. It means that they have an increased risk of it. So once again, kind of like with the celiac disease, we approach a situation where we have to decide where to draw the line and on which diseases. And at the end of this presentation, I'll provide links to 2 recent discussions. One was a paper published in Nature, and one was an actual live debate, where the doctors vigorously debated the merits of offering PGT-P and the potential ethical pitfalls of offering PGT-P. So if you want a better discussion about PGT-P, which again is not it's not been adopted mainstream yet, but probably will be in the future, that's a really good place to look, is that debate or that paper. So to recap, PGT really had two original intents. PGT-A was predominantly designed to allow us to ensure that only euploid embryos were transferred, and PGT-M was there to basically screen embryos for serious genetic diseases so that those embryos would not also be transferred. But as we've seen, the applications of PGT-A and PGT-M can potentially expand beyond that and are continuing to kind of move farther and farther away from their original design. PGT-A also allows intended parents to potentially select the preferred biological sex. In fact, there are examples of fertile couples, meaning that they have no known infertility, coming to an IVF clinic with the sole intention of being able to select the gender of their baby. So they want an XY or they want an XX, and this is the whole reason for doing IVF. And if you can select whether or not your baby produces a penis, then why can't you select for whether or not your baby has the hair color that is desired by both parents, like red hair, blonde hair, dark hair, or a specific eye color, or a specific amount of fast twitch muscle fibers? So although PGT-M is still used for diseases, you could see how it would not be a big leap of logic to also be able to say, hey, but we could look for these things and then select for those things. PGT-P is really interesting because on the surface, it looks like it's just a plus, Yeah, who wouldn't want to, reduce the risk of coronary artery disease and type 2 diabetes and Alzheimer's? But some of the staunchest opponents to PGT-P, which remember is in its infancy, it's a brand new technology that really just started about 3 years ago and has just finished its first clinical trials, is that the information is going to be misused and that it allows us to kind of move towards a sci-fi movie that looks increasingly real called Gattaca, where in the Gattaca scenario, if you haven't seen the movie, it was produced, I think, in 1997. The Gattaca movie, IVF was almost used exclusively to basically select designer babies. So PGT-P, while currently assesses for things like risk of Alzheimer's, risk of cardiovascular disease, and major diseases and disorders, could also be used to test for things like IQ, athletic capabilities. And so you could start to see where you might be able to really assess all these embryos and select, the designer baby. So the current methods right now of PGT, A, aneuploidy, M, monogenetic diseases, and P, polygenic risk scores, are all about selecting. So you have embryos to choose from, and you select a particular embryo to transfer. If you want multiple children, maybe 2 embryos to transfer from that pool. But what about modifying embryos? We're not there yet, but we probably will be soon. And so that will definitely need to be a part of the conversation. Again, right now the conversation is about to what degree do we allow selection of embryos? So how much genetic information do we want to get? And what do we want to do with that? And should there be limits placed on that genetic information? But now let's talk a little bit about CRISPR. So CRISPR is a gene editing tool that has the potential to modify or knock out genes. Its most promising application is gene therapy to individuals who are alive right now, but it has been used on embryos. In China, a scientist kind of flew under the radar and used this fledgling technology to modify the genes of at least 2, but maybe more, embryos, and then transferred those embryos into receptive uteruses. The result was 3 CRISPR babies born in 2019. It was done in China and largely under the radar, But when it was announced that CRISPR had been used to genetically modify embryos, and those embryos resulted in live births, it caused an international uproar. And the scientist actually went to prison for 3 years. In fact, he just got out this year. One of the reasons why this technology is still hotly debated is because it is not necessarily safe. What you see here on the screen looks like a targeted application of a technology. We find DNA that we want to repair or modify. But many studies have demonstrated that CRISPR is sloppy and potentially damages other areas on the chromosome, not just the target spot. So this technology is definitely going to need to improve its accuracy and precision before it even becomes a discussion in the IVF process. But expect that we'll get there one day. And when we do, that conversation will definitely need to happen about using CRISPR to modify embryos and do basically genetic design. Right now, the focus of using CRISPR on embryos is to knock out extra chromosomes, like an extra copy of chromosome 21, so that Down syndrome becomes a euploid embryo. But if this technology improves, we can envision its application to altering specific genes, and then we will truly be in uncharted territory. So I hope that you found this conversation illuminating and enlightening and stimulating. And I talked a little bit about PGT-P at the end, and I cannot stress how new this is. I mean, I went to a conference just 2 months ago, and it was a big topic of conversation there. And so this very first link there is actually a debate from that conference, where you have 2 different sides arguing for the utility or, the against the use of PGT-P and basically because of ethical considerations. And then here's an article that kind of summarizes a lot of those arguments if you're interested. And moreover, this was an incredibly difficult topic even for me to dive into and to really try to wrap my head around all of the nuances. And so here's my extensive bibliography of the many papers that I read to really try to understand and grasp this ethically delicate and very challenging, complicated topic of PGT in IVF. And with that, this concludes our lecture.